This
joining us.
conference will now be recorded.
And thank you for joining us, and thank you for joining Calvet Women Veterans Affairs for our monthly webinar series. Today is August 21st, 2019. This is part 2 of a 3-part series on women's health and women's reproductive health. Thank you so much again for being here today. Good morning or good afternoon if you're calling from the East Coast. We have 3 excellent presenters that you're going to hear from today regarding women's health and women's reproductive health. But first, a few housekeeping items. This is our monthly webinar series that happens at 10 a.m. Somewhere in each month. Today, August 21st, is the second part of a 3-part series. Next month, on September 18th at 10 a.m., you'll hear about maternity care and IVF care to close out the 3rd part of this 3-part series. So a few housekeeping items. Please keep your phones muted so that we can hear our presenters clearly. This webinar is recorded and will be posted on our website at calvet, www.calvet.ca.gov/women-veterans, and you can find our previous recordings going back several years on our tab that says Statewide Monthly Webinars. If you'd like to use the GoToMeeting software, you can also enter your questions in our chat window if you're calling in through GoToMeeting. And if you are, then you'll also be able to see our PowerPoint on our screens. If not, then, and you're just calling in and listening by phone, then please feel free to hold your questions till the end of the call and then ask your questions when we open it up about 15 minutes before 11 o'clock. So now I'd like to introduce our 3 excellent speakers we have this morning. The first speaker you will hear from today is Jody Caton. Jody is a PhD epidemiologist and health services researcher. She's also a core investigator at the VA Puget Sound Health Services Research and Development Center of Innovation for Veteran-Centered and Value-Driven Care, and a research assistant professor in the University of Washington Department of Health Services. After Jody, you'll hear from Ellen Herring, PhD and CEO of Service Women's Action Network, the non-governmental organization focused out of D.C. on women veteran and active duty women's military issues. Ellen is a West Point graduate and a retired Army colonel. She is a senior fellow at Women in International Security, where she directs the Combat Integration Initiative. Her research and work focuses on women and gender in the military. Recently, SWAN published the report Access to Reproductive Healthcare, the Experiences of Military Women, which Ellen will talk about in her segment. And our third presenter today is Kathleen West, MPH and a PhD, a doctorate of public health. Kathleen is a public health professional working with programs serving high-risk maternal and child populations, public mental health, intergenerational trauma, and addiction issues. Her UCLA doctoral work focused on reproductive epidemiology and health policy, specifically on prenatal drug exposure and subsequent child development and placement outcomes in the context of dependency court decisions. So first we're going to hear from Jody Caton. So please again make sure to mute your phones and welcome Jody.
All right. Hopefully you can hear me. I'm unmuted. And it's a real honor today to share the results of a systematic review that myself and my team recently conducted on the literature with respect to women veterans and reproductive health. If you can go to the next slide. All right, so these are just the standard disclosures. I have no financial conflicts of interest, and the views that these are my own and do not necessarily reflect the position or policy of the VA. Next slide. More importantly, I've increased, go back one slide, please. Thank you. I've been increasingly making sure that I make this disclosure, which is a personal disclosure, and that is that neither myself nor my immediate family members have served in the U.S. Armed Services. So I'm speaking today about research, including some of my own results that don't necessarily reflect my own lived experience, and that needs to be taken into account. All right, next slide. Okay, so it looks like the animation on this slide may have been a little off. But to give you some background on this work, I wanted to describe the VA Women's Health Research Network, which was founded and first funded in 2010. And this research network is comprised of two pieces: the Women's Health Research Consortium, directed by Dr. Becky Yano in Los Angeles, and the VA Women's Health Practice-Based Research Network, which is directed by Dr. Susan Frayne at VA Palo Alto. And so collectively, these two pieces make up the VA Women's Health Research Network, which is really designed to support ongoing research in women's health within VA. And so just to give you an idea of the success that this network has had, within the first 3 years, they managed to exceed their stated goals in terms of both funded grants as well as published peer-reviewed manuscripts and journal supplements. Similarly, over the following 3 years, so I call this the WHRN 2.0, this network managed to get more than 12 VA HSR&D Career Development Awards funded. So this is basically a way to launch young investigators, and my Career Development Award was part of this, as well as 2 additional funded journal supplements. And the work I'm going to be sharing with you today is really from year 7 and beyond, specifically this first bullet point in that last box, which is leveraging the existing evidence map to create summaries in specific areas. So a few years ago, there was a review conducted of all of the literature with respect to women's health, women veterans' health, and looking broadly at different categories, including reproductive health. And so, but this evidence map merely indicated where there'd been areas, what topics there had been areas of growth, and where there were sort of more continued interests, and where there were remaining gaps. It did not actually synthesize the results of these studies. And so the work that I'm presenting today is the synthesis of these studies that were focused on reproductive health. Next slide, please. All right, so what was our motivation? So first and foremost, there are continued questions from veterans themselves, from VA leadership, from Congress and the media, both with respect to the role of military service in reproductive health and the impact that military-specific exposures may have, as well as how and whether VA is providing sufficient services for women veterans. Additionally, with the continued support of the Women's Health Research Network, there are a growing number of researchers in VA who are focused specifically on reproductive health of women veterans. And these include researchers from a variety of disciplines: psychology, primary care, gynecology, health services, epidemiology, and others. If you can hit the next, there should be one more animation. All right, and so as a result of the growing number of researchers and increased support, we've also seen a rapid increase in the literature. So the knowledge base is growing, but it had not until recently been summarized and synthesized. Next slide, please. All right, so as part of my involvement with the VA Women's Health Research Network, I co-lead the Reproductive Health Work Group, which is comprised of about 40 VA researchers and providers. And I was able to leverage this work group to conduct a systematic review of the literature. So we specifically looked at articles that were published between 2008 and 2017 because prior literature reviews had included literature that was published before 2008. And this work that I'm sharing represents the work of actually 20 different individual study team members who are part of this work group because there was such an extensive and rapid growth in the literature. So to identify articles, we searched existing online databases that include health services and research. We scanned editorials, case reports, review articles, and reference lists. So we really tried to cast as broad a net as possible. And then after doing an initial review of titles and excluding articles that didn't fit our criteria, we then had study team members review abstracts to decide which articles would be eligible for full review. And then for those that were chosen, we had the study team members using a standard abstraction form review and collect certain information from each of the included articles. Notably, both the abstracts and the articles were all reviewed by multiple study team members, and we did this to ensure consistency, both in terms of decisions around inclusion and exclusion, but also consistency in terms of the information that we were extracting from the articles. Next slide, please. All right, so this slide just details our exclusion. We excluded articles that weren't in English, that didn't focus on reproductive health or healthcare, those that included a very small portion of women veterans, and those that either did not explicitly address results for veterans or did not explicitly address results for women. Next slide. All right, so we identified 52 articles, and this represents a tremendous increase in the peer-reviewed literature. As you can see here, we categorized these articles into 7 different categories. These included sexual behavior and sexually transmitted infections, or STIs, contraception and preconception, infertility, pregnancy, gynecology, menopause, and this last category, which we termed delivery of reproductive health services. So this included studies that looked at the organization of reproductive health services within VA, as well as different types of strategies for training VA healthcare providers. Next slide, please. All right, so what were some of our key findings? So first and foremost, as noted on as you could see on the prior slide, the majority of articles focused on either contraception or pregnancy. So this was the area where we saw the most growth in the knowledge base. If you can hit next, all right. However, there really were still some significant knowledge gaps where there was just a dearth of published literature, and these included STIs, infertility, and menopause. If you can hit the next button again. And then nearly all of these studies were observational. So these are studies where we're pulling data or we're conducting surveys. We're not actually testing interventions or testing modifications of proven interventions for effectiveness within VA. And so there's many types of research questions that can only be answered via observational studies. However, when we talk about improving healthcare for women veterans, I think there's an open question as to whether we have enough of a knowledge base to start to move more towards interventions with respect to reproductive health. And so this is an area of needed growth and development. Next slide, please. All right. So some additional key findings specific to areas of knowledge growth. Despite increased access to contraceptive services, there are still policy and system level barriers that exist within VA. And this was highlighted by a paper that came out after our systematic review from colleagues in Pittsburgh. Senior authors Dr. Sonia Barrero that highlighted the challenges that providing only a 3-month supply of oral contraception versus a 12-month supply created for women in terms of their reproductive autonomy and ability to avoid unintended pregnancy. If you can hit next again. All right. The other area of growth we saw, of tremendous growth that we saw, was in the area of pregnancy. And collectively, these studies really strongly suggest that veterans who use VA maternity benefits, those who were previously deployed or those with active PTSD, may be at higher risk for relatively common pregnancy complications. And this includes hypertensive disorders of pregnancy, specifically preeclampsia, which is a very severe form, gestational diabetes, which is diabetes that first is diagnosed during pregnancy, and then typically postpartum will go away, and spontaneous preterm birth. And what's important about this is not only the short-term health implications for both the pregnant and delivering person and the baby, but also that these have long-term health implications. Specifically, preeclampsia and gestational diabetes are both considered to be markers for increased risk of later development of type 2 diabetes and cardiovascular disease. So when we think about healthcare prevention and caring for veterans across the life course, these are important issues to consider. If you can hit next. All right, and then finally, across all topic areas, what we saw in the literature was really this in this sort of cross-cutting theme of the negative impacts of both sexual assault and mental health on reproductive health outcomes. And these negative impacts really spanned across the life course, so everything from preconception to menopause. All right, next slide. Okay, so what does this mean? What are some of the implications in terms of policy and practice? I think that these findings really, highlight the need for ongoing support for research on reproductive health and healthcare within VA. This is particularly with respect to some of the areas where we saw a deficit in the literature, so infertility, STIs, sexual function, which I didn't mention earlier, and menopause, but also some of these areas where we are seeing an increase in the peer-reviewed literature, and we may be ready to start to move towards testing interventions. There's a need for continued VA quality improvement, both around contraceptive and maternity care. We've come a long ways, but we can still, there's always room for continued growth. And then given this cross-cutting theme of the role of mental health in reproductive health outcomes, considering models for integration of reproductive health and mental health care is really necessary and probably a key, and might be a key bit about for these continued quality improvement efforts. And then finally, really focusing not just within VA, but broadly outside of VA in a number of settings, thinking about what we can do in terms of prevention of and support for survivors of sexual violence in all settings and institutions. And I just want to end this part of the presentation, if you can go to the next slide. So I'm not going to read this full quote, but this is from our paper. And essentially, really highlighting the tremendous burden of sexual violence, both nationally as well as within the military and veteran populations. And also, thinking more specifically about what is needed, both in terms of prevention and also in terms of care. And so specifically, training VA providers and staff in bystander intervention, trauma-sensitive or trauma-informed care, and how to ask about lifetime, not just military sexual assault. If you can go to the next slide. So in addition to all of my co-authors, I have numerous collaborators, mentors, and great study staff here at VA Puget Sound, as well as at other VAs. And I, of course, want to acknowledge my operational partners in VA Women's Health Services and the Office of Health Equity, as well as my variety of funding sources. Next slide. I've included some references, so if you go back to the recorded talk, you can look these up. Next slide. And I really do want to encourage you to reach out if you have any questions that don't get answered in the Q&A or want to follow up about anything that I've shared here today. I've included my email here, as well as I'm on Twitter, so I included my Twitter handle. And you can reach me via either of those mechanisms. And so with that, I'll conclude, and we can, I guess, go to the next speaker. Thank you.
Thank you so much, Dr. Caton. I really appreciate you taking the time to update all of us on where we are with literature and research regarding women veterans. It's something that I think a lot of our women veterans here in California, as well as policymakers, are keenly attuned to and paying attention to what the latest developments are and how we can all contribute to improve policy or even partake in the research. So I'll have some questions for you at the end of our presentation along those lines. So I appreciate the information you're sharing. This is very important stuff. So next, I'd like to welcome Dr. Ellen Herring, who is the CEO of Service Women's Action Network. Dr. Herring, thank you so much for joining us, and we look forward to hearing from you.
Thanks for having me. So I guess you can go to the next slide. So in 2018, we decided to do a little study on women's reproductive health care. And the reason we decided to do this study was because we are a member of an organization. Actually, it's a coalition here in DC that looks at women's reproductive care across the country. We're the only organization that does military women. And the coalition had a long time told us that there was problems with access to birth control in the military, but we had not had that experience. And we were actually veterans and serving members of the military. So we ended up conducting this small study. We had received a small grant from the Mariah Fund to determine whether or not access to reproductive care, where the problems might lie, and in particular in 3 specific areas. So this coalition had been telling us that women didn't have access to birth control. So one of the areas we were looking at was access to birth control. The second area we decided to examine was abortion rates and access. And the reason we just looked at that area is because we frequently get calls from women looking for help with access to abortion. And then the third area that we decided to look at was infertility. And I'm not even sure exactly why we put infertility in there, what our thinking was at the time, but that turned out to be one of our biggest findings. So just a little background on the survey. We developed a survey. We developed it in conjunction with and support from 2 universities, University of California, San Francisco, and then University of Washington researchers. I can tell you what their departments are if anybody wants to know, but I don't have it off the top of my head. So we developed what we thought was a pretty comprehensive survey, and we've just began to, basically it was a snowball survey. First it went to our members, then as well it went to Facebook groups and other organizations. At the time, the VA shared it as well on the Center for Women Veterans website. And we ended up getting about 800 participants. Unfortunately, it wasn't a very good demographic breakdown, or not very representative, because it was approximately 50% officer and 50% enlisted. And we know that that's not the population that's out there, because it should have been about 80% enlisted, 20% officer. So we know it's a little bit skewed. It's also skewed racially, because there are 75% of participants were white, and the remaining 25% went from other minority groups. And in the services, actually, minority women are a much larger percentage than minority men. And in the Army in particular, minority enlisted women actually outnumber white women. So we know that we have a skewed population here. It's skewed towards officers and it's skewed towards white women. Despite that, we did have some interesting findings, and we did eventually we disaggregated the data and looked at officer and enlisted to see whether or not there was a different experience once we looked at them separately. Okay, so that's the background, that's the population. Can you go to the next slide? Okay, so this is a slide that just pretty much summarizes our findings in the 3 areas that we were looking at. So we're looking at access to contraception, access to abortion, and then of course infertility. The thing that shocked us and very much surprised the entire group was researchers was the rate of infertility. Now remember, this is self-reported, and it could have been that people who had problems with infertility were more likely to take our survey, or had problems writ large with any of these areas were more likely to take our survey. But the infertility piece was actually the last piece of the survey. So they had to get through most of the survey to even get to infertility to know it was in there. So as you can see, if you look down about the second from the bottom bullet, I had trouble getting pregnant and actively trying to get pregnant. We had a 37% response rate from active duty women, and it only went down to 31% with the retirees. So in that entire category there, it was relatively high, especially, and it was dramatically higher than the civilian population, which stands at 12%. We also had some interesting findings relative to the access to birth control. I think it was 80 women said that they'd had an unintended pregnancy that they terminated, and of those 10 said that their unintended pregnancy had been the result of a sexual assault. And then, of course, the military is not allowed to provide abortion care except in the case of rape, incest, or life of the mother. And 4 of the 10 women who'd had those unintended pregnancies due to a rape said that their pregnancy had been terminated in military facilities. The last finding of note was about birth control access during deployment. So birth control access seems to be getting much better as long as you are stateside or CONUS or you're in a fixed location. It degrades significantly when you deploy, but seems to be getting a bit better over time. The number one reason for not having access was that they weren't prescribed enough birth control to cover an entire deployment, and when they needed refills, it simply wasn't available, or it would arrive late. That was the biggest complaint. But there was one other complaint that surprised me, and that was that some providers, believe it or not, say that if you are deploying, you shouldn't, because of general orders, you shouldn't be having sex. Therefore, they are denying some women access to birth control, even though that's not necessarily the reason women use birth control during a deployment. Can you go to the next slide? So, well, I guess one other thing I should have mentioned is when women have problems with infertility, they have few choices with active duty and even fewer choices with the VA. So with active duty, the full range of infertility options are only available at a few locations. And even at those few locations, there are 5 locations, there are long waiting lists. And women have to cost share some of the care, especially if it requires IVF. If they go to the VA and they need IVF, any infertility care at the VA seems to be very much dependent upon the provider that is approached. The VA hospital, some hospitals are better about providing the care than others. And I don't know that's because they have the care available, but even the referral process seems to be better at some places than at others. But either way, IVF is not covered. It's my understanding it's not been covered at the VA yet. The second thing was about the abortion services provided by active duty versus the VA. So in active duty, like I said, it's covered in 3 specific cases. But at the VA, it is not covered even in those 3 specific instances. So even if you are raped, the VA does not cover abortion services or care. And so that all these have led to several recommendations, which we have on this page. Now, our number 1 recommendation is that we conduct additional research, because ours is a survey. And of course, surveys can always be skewed and biased. So what we would like and what we've asked as we have shared our report with members of Congress is that DOD and the VA be required to do more in-depth research specifically into the infertility issue. And when we asked this, actually, as we were delivering our report and sharing it with people, we were approached actually by a number of men who said that they are also infertile. So the research request that has already been written into both the House and the Senate NDAA is to look at infertility in both men and women, and that a joint research report or some kind of joint research effort occur between the DOD and the VA to consider, how it impacts veterans. I think there's some problems associated with the 2 organizations apparently collaborating on research, but I'm not sure how that will work. So that was our biggest recommendation, is that we need to do more research. It shouldn't be survey-based. It should be actually a review of records. I don't know how that would work, but that was our primary recommendation. Then the other recommendation that we had had to do with this abortion services and post-abortion care. Several of the women who had received abortions had complications. And when they was reported or needed help with the complication, they were treated very poorly. And the treatment that they received at the hands of active duty military caused kind of I would call it emotional or mental wellness scars, on top of the fact that they had been afraid to either approach their providers, or if they had approached their providers and been turned away, then if there were complications and had to be dealt with, they were further kind of mental scars associated with their whole experience. The one thing that we recommended is that even though the active duty side and the VA cannot provide abortion services, that they at least advise women where to go to receive safe services, and that if there are complications, that they be cared for appropriately, not shunned or shamed for what they had experienced. And the more significant complication came from women who were stationed overseas, especially in countries where abortion is not allowed. For instance, in Korea, it is not allowed. And women who have unintended pregnancies in Korea have an even more difficult challenge about what they're going to do about it. The last thing is that if in fact, even if it's not that we have high rates of infertility, we think that they should provide the full range of infertility at no cost. If their infertility is caused by military service, then there's absolutely no reason that they shouldn't be getting the full care that's available. In our follow-up, we did a number of follow-up interviews with people who participated in the survey, and we asked them, why do you think you've had these problems? And especially relative to the infertility question. And we received a lot of responses saying that they felt like it was exposures to toxic environments that they had been in during deployments or on military installations. One woman said that hers was clearly the result of wearing body armor that didn't fit, that caused hernias, and she's not able to carry a baby to term. So there were a number of reasons or suspicions on their part for why they were infertile. And I think that would be a good place to start with the research, is to actually ask the women and then go into the records and try to determine. And then, of course, the men, and not to ignore military men might be also having a similar impact of exposure. So those were our 3 recommendations. We hope we filled one of those areas that the previous speaker mentioned about a dearth of information. I will say, too, that when we first published our report, we got some pushback initially from, the VA and some other, it was kind of private pushback, or it was public, actually, that we didn't know what we were talking about. And then I was afraid that in fact we didn't have the most accurate data, but I could not find solid data on infertility rates. And when we asked DoD about it, they said that the last comprehensive women's health assessment had occurred in 1989, but that this year they had contracted with Rand Corporation to do a comprehensive women's health assessment. And but however, I believe it's going to be survey-based and not records-based. And I don't know whether one is better than the other, but Rand is working on that now. So that's all I have. Thank you very much.
Thank you very much, Dr. Herring. That's very interesting information. Surveys can be challenging, particularly snowball samples, and so I think in spite of those challenges that you expressed at the beginning and where the demographics may not have been as representative as you'd hoped, it sounds like these recommendations are pretty consistent with what I've heard from women veterans in California, from what a lot of our service providers and women's advocates kind of say in the range of issues that either women bring to them or that they've experienced themselves. So not foreign or not kind of surprising, unfortunately, at all. So this is really good information. And it does kind of seem to connect to what Dr. Caton said as well, where there needs to be some more literature and research, what we focused on versus versus what we could continue to look at in terms of the gaps of what's being provided by the VA or what military service may cause in terms of injury and disability. So thank you very much. Now I'd like to welcome our next speaker, Dr. Kathleen West, and she'll be talking about military-connected women and family formation in the context of reproductive health. So Kathleen, thank you for joining us.
Hey, good morning. And thank you to the previous speakers who were very informative. I'm lucky to be able to refer back to some of their comments in my comments here. So I'm going to be, I guess, sort of take a large approach, big picture, as well as then kind of diving down into some details with some hopefully policy recommendations as we move forward. But Lindsay, can we have the next slide? Thank you. So these are some of the questions that I hope we can cover in the next 15 minutes together. They're very big. Some of them are somewhat rhetorical. Number 3, for example, are women veterans different than civilian women? How and why? And hopefully that will be, I will explain why I'm asking that question. And I think it needs to be asked as we think about women veterans' identity or their multiple identities and what that means for their family formation and their reproductive health. And the reason I also want to just mention that as I'm speaking about family formation, I want us to keep in mind that reproductive health has an outcome or reproduction has an outcome, and that is the addition of a new person into the constellation of someone's life in the context, in this instance, of their military service. And I also am going back and forth in this discussion between active duty, reserve guard, and veteran status, because a lot of our veterans actually are members of the Guard and Reserve and continue to serve that function. Also, a lot of, they're all by definition prior enlisted. And keeping in mind that when they take off that uniform, and also, like Jody, I am not a former service member, but have been involved in this arena for a few years. That identity may or may not stay with them in an important way, but it has probably had some sort of influence on their physical well-being and their life experience, obviously. So I want to kind of think about these in big ways. So next picture, or next slide, please. Excuse me. So reproductive health is embedded in a larger picture of well-being, and I'm afraid this is a little bit a light rendition of this graphic, but kind of thinking about the larger general health, physical health, mental health, social well-being, in which reproductive activities, becoming pregnant, not becoming pregnant, wanting to be pregnant, infertility, becoming a parent, a mother in this case, all takes place. So we know that overall, actually, our military service members are at higher levels of fitness because of the recruitment standards. Although there have been waivers over time, for the most part, they're generally physically healthy and mentally healthy when they are joining the service. Sometimes they're not emerging as whole as when they entered. But it also, we also have literature, more than just this article by Ursula Kelly, talking about greater experiences of traumatic exposures than their non-military peers, which means that we really have to keep in mind that trauma-informed care ought to be provided from day one. The Army has actually talked about using adverse childhood experiences, the ACEs tool, as a screening tool for recruitment, which has been relatively controversial since that's priority where there's no possibility of intervention or compensation for that. It may be worth considering and to consider wraparound.
Kathleen, we're having a hard time hearing you. Can you repeat that last part, please?
Oh, I'm sorry.
That's okay.
Yeah, what I said was the issue around the need for trauma-informed care is something that ought to be considered for wraparound services for both our veterans and our service members, because what we know is that there are prior traumatic exposures that service members have disproportionate to their to civilian counterparts. Are you hearing me better now? Is that coming through?
Yes. Yes,
Okay.
much clearer.
Okay, thank you. Next slide then. This is a busy slide, but one that I think is really important, and this is where we're getting very concrete. Thinking about where do California women veterans live. This is based on VA population projection estimates, which is really the best, probably the best data that we have right now. It's actually only accurate to about 1,000. So these are very rough numbers, even though they give you right down to the right down to the last little almost decimal. But what this shows us is that in California, we have 43% of our women veterans of childbearing age, which is the 17 to 44 population, live in 4 counties, which is consistent with the rest of the California women veterans across the board. And a full 78% of California women veterans of childbearing age are in just 12 counties. So when we are thinking about what we need to do to provide services, what kind of policies we want to put in place, what supportive services, it would really make sense for us to be focusing on this population. Of course, the downside of this is that we have the other population, the other 20% roughly, are in counties where we may not be providing as many services. I will add here, and we're going to kind of a foreshadowing of the last slide, is that we have OBGYN shortages as noted by the American College of OBGYN, emerging in 3 of these key counties, in San Diego, Los Angeles, Riverside, actually in Sacramento, I misspoke, it's not San Diego, it's Los Angeles, Riverside, and Sacramento. We have a shortage of about 8,000 OBGYNs in California in those 3 counties, which is significant given that our VA does not provide deliveries. And while there are more OBGYNs that are serving in VA facilities, the deliveries and the prenatal and postpartum care tends to still happen with our purchase care contracts for the VA. So just thinking about how we want to target our services is important in California, and thinking strategically about the population that we're looking at. Next slide. So this is a slightly bigger piece. California is used to being kind of #1 almost all the time in terms of veterans and active duty and military installations, et cetera. But in this instance, we're #3, means we still have an awful lot of veterans, women veterans in California. And what I want to kind of note here is that 41% that you notice in that first column reflects the childbearing group that are in these 6 states. So across the United States veteran population, what we're seeing is that those 6 states represent 41% of all women veterans in the 20 to 49 year age group. Average age of menopause in the United States is 51 years. So it's fairly safe to say that that really is the childbearing age group. And I think that's kind of the biggest piece. But as we're thinking about what we might want to be doing on a larger scale, with some of the questions about research, about policy needs for this population, if we were to partner among these 6 states with women veteran researchers at the national level to do further work on women veterans of childbearing age, for example, it would actually be manageable and viable to do a multi-site research project that would capture a huge percentage of the population that we really want to be looking at, just including these 6 states who are where a lot of our former service members are moving to as they separate from service. So next slide. I want to look at, this is a general population, civilian workers, active duty, Guard and Reserve. So it isn't referring to veterans per se, but this is data from DOD and from the US Census Bureau that is showing basically a younger age of family formation among our active duty population. At an average age of 28, you're seeing that with 14% female population, 18% female in the Guard and Reserve, they have 2 children by the time that they're 28 years old. And that's 44% of them have 2 children. So it's, I think it's really important to keep in mind that our active duty population skews younger, but has the same number of children, and that they're forming families at earlier stages. This has a lot of implications for economics, education, et cetera, which we'll get to in the next few slides. So next slide. So this is data that is actually from the CDC. The citation is on the next page, but what we're seeing is that the chart on the left side is from 1980. The chart on the right side is from 2016. And what we find is that we have overall US women are having their first child at much later stages. There is a gap among the coasts and the middle parts of the country, which we'll see in the next slide in a second, but it's also a gap among service members, and veterans and civilians, is that we have family formation still happening at younger ages in our military connected population. Next slide. So what you're seeing here at the chart is that the average age of mothers is rising. This is in 2016. The average age was 26.3. The green colors on the map indicate where you're seeing that population localized, and the deeper purple are with the younger age population. So this was the average age that was changing over time in the United States overall, which has a lot of implications, as we'll find out, for our military population too. Next slide. Why this is significant is we find that our military veteran, this is veteran actually, veteran status, our veterans are marrying. The pale green is the veteran. The percentage of them that are married at young ages is much greater, almost 30% versus 9% for the non-veteran population. So while this is data that's a little bit outdated, it tends to be consistent with what we're still seeing today, and it's the best, I think, most current data that we have on this. And then what you see over time is that that percentage of married status by veteran status drops. And so we see that veterans over their lifespan tend to be married less consistently, or less often perhaps, that may not be the case, we'll get into that in a minute, than their non-veteran population. Next slide. So this is where you see the divorce status, and this is really significant, I think, for family formation, for reproductive health, for thinking about primiparous and multiparous populations. So primate means a woman having her first baby, multiparous is multiple children. And the slide that we saw earlier on the map was looking at age of first child, right? So the age of first child among the general population is rising dramatically. That seems not to be true among our active duty population. However, they are having more children at later ages, which we'll get to in a minute too. But you see the divorce rates are higher across the lifespan for our veteran women. And that's of real concern. It doesn't necessarily mean that they're not married, but divorce always has complications. It means they're in family court more often. It means more child custody issues. It means oftentimes there are periods where they may not be housed because they may not have enough resources to do so. It has lots of economic implications. Next slide. So this is, again, the maternal age at first birth. This is for married women. You see that the married women population, again, implications because veterans are included in this data. The average age for married women is 28.8 for the first birth. And you can see that's tracked with the older ages skewing in the green parts of the map. Next slide. This one is looking at college degrees or higher. This tends to be actually really good news for our veteran women who tend to be doing great at getting their college degrees. They are using their GI Bills typically at great rates. They are tending to get better education once they separate from service. But you see that the maternal age at first birth is much higher for those with college degrees. And that's just kind of what this is. That's all this is intended to say. There's nothing kind of more to look at this, but it's significant in that we really want to be encouraging thinking about this in the context, and we also want to be considering encouraging our service members, veterans, to take advantage of the GI Bill, and then considering what this has to do with where they stand if they already have a child when they separate from service, what that's going to mean when they're in their college years, and kind of services for them to support their families. Next slide. I'm going to go fast here since we've got a shortage on time. But what I really also want to kind of get to here is that while there has been a huge increase, a 175% increase from 2000 to 2015, which was shown in the source book, volume number 4, from the Barriers to Care done by the VA, released in February of 2018, shows that we still have a relatively few number of women not using the VA as their primary healthcare source. And only 11.5% were using the VA for healthcare only. So I guess my argument on this one, we can move to the next slide, is that we really ought to be thinking about these other women. Where are they getting their care? We need to make sure that whoever is providing their care for them, which is usually our purchased care providers, which the VA oversees, for their reproductive health care, especially maternity care. We need to make sure that those providers are socioculturally competent. We know that overall, our female active duty are less likely to be married than their male counterparts, and they are also more likely to be married to another active duty service member. And really, even though that's still a minority, it's significant. It has implications for parenting, childcare. We already heard some comments about infertility. It may have implications for that as well. If we can move to the next slide. We want to make sure that management of menstrual periods, which were mentioned by Ellen, in terms of access to continuum of contraceptive care while they are in active duty is really managed well. And we want to think about what kind of stigma pregnant women do experience while they're active duty, and what that may have implications for their subsequent pregnancies as veterans. Let's go to the next slide. I think this is a really important piece that we have not fully considered. The implications of the full force integration policy, which is still being implemented in fits and starts, means that more women are going to be coming back with the same exposures as men, which we really don't know what that means for them and their unique reproductive health status. It also may have implications for their readiness for family formation, for family engagement. And we see that this is where you see more active duty dual marriages, which are important to consider in terms of family formation. Okay, next slide. These are some of the risk factors which we've already discussed, so I probably won't belabor this here, but we have a lot more MST, as Jody mentioned, across the population. That depression that tends to accompany that exposure, whether you're civilian or military, persists across the VA. It's one of the top 3 problems reported by women in the VA across all age groups. And we just need to keep in mind that we really still have a lot of women that are facing combat even now. And that has implications for their healthcare and for their family formation. Next slide.
Kathleen, can we do this slide and then open it up for questions among our presenters?
Yeah, can you just jump to the very last slide then, or the last 2 slides, Lindsay?
Sure.
There we go. Oh, wait, actually, just one back.
Okay.
Actually, I'm sorry, one back. We'll just do this one instead. Okay. So I think all of the foregoing has implications for reproductive health care needs. And I guess this is where I really want to close. The next couple of slides are just what ACOG recommends. But I think we really need to make sure that we're engaging with this non-VA community-based providers to make sure that they're competent, since they're providing a lot of the care. And I think that all of the details that have been provided both here and in the previous 2 presentations are something that most OBGYNs do not know, and are really important for them. This was a 2012 recommendation from this committee that they engage, and it really hasn't happened very much. So I think we need to be more aggressive in advocating for better services in that purchase care component, which is only going to increase with the Mission Act, which was implemented at the end of June of this year. So thank you very much for that. And Lindsay, thank you for being such a great slide mover here. Thanks a lot.
My one job in life, folks, is moving slides, so you guys can give important information. So I would like to open this up for questions. We might end up going a little bit over time, but I want to be respectful of everyone's time that you guys have spent with us today. So first, if anyone has questions that they can do on the chat window, if you're on the GoToMeeting software, that would be great. Otherwise, if someone's joining us just by phone, let's please ask questions by phone. So does anyone have any questions for our 3 excellent presenters at this time? I know we had one question, Kathleen, for you that was asked where you were getting your VA data, your women veterans population data from by state.
That is from the VA statistics page. So if you go to the population site, and then Lindsay, I think you know where this is from, and then you scroll down to the other demographics, or I think it may be other information, but I'm happy to send that to whoever asked that question, but it's actually from the National VA Population Statistics Service. Yeah.
Right. Yeah. The Vet Pop is the kind of short-term use of that, and then it does go by state and then by gender and by county as well. So, and I can certainly send the much larger spreadsheet to anyone that may request it as well. But it's useful information. So I have a few questions going back to our first speaker, unless someone wants to ask something really quickly. Okay, so Dr. Caton, as far as this literature review that you all have done, are there plans to summarize more literature reviews in the future, or are there plans to take the summary that you've done and continue to publish this information, making policy recommendations, et cetera?
Yeah, that's a great question. Actually, while we were after the piece had been accepted and while we were waiting for it to publish, there were at least 5 additional articles that came out. And I also happen to know that some of the research gaps that I alluded to, we're waiting on some ongoing studies that should be publishing their data in the next few years. So the short answer is yes, I think there's going to be an ongoing need to update this systematic review, but I'm not sure what the time frame for that would be. It's quite an undertaking, and so that is a challenge. In terms of speaking to policy and getting this information more widely disseminated, we, as part of the Women's Health Research Network, produced several what we're calling snapshots that were basically sheets that summarized the information regarding specific areas. And those were used both for some congressional briefings, but also for VA Research Day on the Hill. And we're working on ways in which we can more broadly disseminate those as well. I have an ongoing interest in dissemination through things like fact sheets and virtual and visual abstracts. So these are all things that are underway.
That's excellent. We would be happy at the state level to help disseminate that information if you wanted to get it out to the broader public, or even to help within the two VISNs that cover California. So we're always happy to help support getting more information and research out there once it is produced. We do have a statewide Women Veterans Leadership Council here in California that has members that represent all different areas of the state geographically, and we have a pretty extensive network of women veterans that we communicate with. So we can certainly get it out to that population too if it's of interest.
Yeah, I would certainly love to have that conversation offline about what would be possible.
Okay. Yeah, I see an opportunity perhaps to have the three of you back either together again or at different times to continue getting updates about what research you're working on. As it's been kind of brought up with my staff, who I want to thank for putting this webinar together and coming up with the ideas around women's health care, in particular reproductive health, maternity care, et cetera. They did the work to contact you all and put this together. But we see this as an ongoing issue where more and more cases of infertility are coming up, access to birth control, access to preventative family planning. All of these things are coming up pretty regularly among our women veterans population. And one thing we're also not discussing, which I think your research points to, Dr. Caton, is that there is still a need to talk about women when they're in the menopausal years as well. And not enough research is being done on that. And our population still skews to women who are entering those stages of life. So we need to be responsible.
And that's an area I can tell you that we actually had 2 years ago, I think she's in year 1 or 2, a career development award focused specifically on that. So there's going to be some excellent work coming out of the VA in San Francisco with respect to menopausal needs. And there's also some work that is in process in Tampa as well.
Wonderful. Wonderful. Well, we look forward to that. We do have another question from, I believe it's Zaima. She's asking, how is the Mission Act improving veteran women's reproductive health care needs? That's a fantastic question, given that the Mission Act is newly implemented this year. Dr. Caton, do you have anything to comment on for that? Or Dr. Herring, are you seeing anything among your population, your constituency for that?
I have a personal experience. I use the VA as my sole healthcare provider, and it doesn't seem like, at least I go to the Washington, D.C. hospital and had to go there recently and ask them some information. Nobody at the hospital could answer questions about it for me. So it was a little frustrating. It seems that the providers themselves aren't really fully sure of how it's going to work.
Yeah, so I would add that this, it just took effect, and this is following the Veterans Choice Act, which had a number of bumps, particularly with respect to women's health care. So I think it's yet to be determined What was alluded to specifically, though, regarding shortages of providers in the community, I think is a real concern. We know specifically in rural communities, there have been closures of obstetric units. We know that generally in rural communities and some other areas, there are shortages of specialty care providers. And so it's not clear to me necessarily that there is this pool of providers waiting to care for the veterans who we send out. And so I think that that's a bigger issue in terms of shortages of providers that the Mission Act can't in and of itself address.
Okay, yeah, really good point there. The ongoing issue of a shortage of providers is not getting any better, in other words. So, okay. Okay, and it sounds like we need to do a lot more research and provide more information about the Mission Act to our population. So I think we've just gotten a suggestion for another topic for one of our future webinars, so thank you. We'll look at the Mission Act next. Any other questions from our attendees and participants in this webinar today? So it looks like we're going to try and provide some accompanying information as well when we include this link. So I'll talk to my staff about putting that out as well. We can certainly put this PowerPoint out as well, or any other handouts posted to the webinar. Expect about a week turnaround time for us to get this webinar posted onto our website at calvet.ca.gov. If there are no other questions, because I want to be respectful of everybody's time, we'll go ahead and conclude this. I would like to say thank you so much to Drs. Caton, Herring, and West for coming on and speaking with us about the important topic of women veterans and our healthcare needs and reproductive health. This was incredibly informative and great information. I think we'll have more to come on these subjects, and I look forward to speaking with all three of you again on this. Please join us again for the third part of this series on September 18th at 10 a.m., where we will focus on maternity care and IVF care for women veterans. And if you have any questions for us, or if we can provide anything to you information-wise, or anything about your benefits or about this webinar, our email is womenveterans@calvet.ca.gov, calvet.ca.gov. Our phone number is 916-653-1402. Thank you again for joining us. We look forward to seeing you again next month. And thank you to our wonderful speakers today. We appreciate it very much, ladies. Thank you.
Thank you.
Thank you.
Thanks.